3:30, so let's go ahead and get started. We can. All right. Glad to have you all here. My name's Tom Robinette. I'm going to be the moderator this afternoon. I've told a couple of people already that Tara and Reagan were digging down around the bottom of the barrel and found this old retired guy and said, "Do you by any chance have a conflict today?" And I said, "No." And they said, "Well, okay, would you be the moderator?" I said, "Yes, I'll try." So I want to thank all of you for attending. It's great to see people out and interested in such an important topic. What we'll do, first of all, I'll let our five panelists introduce themselves, talk a little bit about their backgrounds, and then we'll go through some previously prepared questions, 7 or 8 questions that we've got, and let 2 or 3 of the panel members address each one. And then I think at the end we'll have some time left for questions from you all, things that come to your mind or are already in your mind. So we'll start, matter of fact, we might just start and let each panelist introduce themselves, just a couple of brief comments about your background, and we'll start right here with Ed.
Okay, thank you, Tom. Appreciate it. My name's Ed Klump. I'm retired from the Topeka Police Department. I spent a lot of years on the night shift, so I spent a lot of time in emergency rooms. Fortunately for me, not many of them as a patient, so but I got to see a lot. After my retirement, I was chief of police when I retired, and after my retirement, I started doing lobbying as a contractor for the Kansas Sheriff's Association, Kansas Association of Chiefs of Police, and the Kansas Peace Officers Association. And I think I'm here because I've been involved in this process since it started, and I don't even remember when that was. I know it's prior to 2015, trying to get a bill like this passed, and so I've got some experience on trying to get it through the legislative process, and it sounds like maybe we're going to get at least part of it passed this year. So that's my story.
Okay, Alan.
Good afternoon, Alan Verrill. I'm the CEO of Advent Health South Overland Park, the newest hospital in the Kansas City region. We opened up on October 7th of 2021. It's been exciting to join the community as another healthcare provider. By training, I'm a physician with over 30 years of experience in healthcare at this point in time. I'm an internist with most of that time clinically, 20 plus years of clinical medicine practice as an internist and hospitalist. So I've spent my professional life in hospitals providing care to the communities I've served. That's both been within the Air Force in Maine for 15 years of practicing clinician, and then 2015 transferring to Denver, where I served as a chief medical officer for 5 years in Littleton, Colorado, at a hospital there prior to taking this role here in 2020. So thank you. It's a pleasure to be with you today.
Thank you. And Heidi?
Sure. Good afternoon, everyone. My name is Heidi Boehm. I'm a program manager at the University of Kansas Health System. My primary focus is behavioral health, quality, and safety initiatives, with one of those initiatives being workplace violence prevention. I've been a nurse for over 20 years, and I also helped co-found the Kansas City Metro Healthcare Workplace Violence Prevention Collaborative, and it's a pleasure to be here with you all today.
And Christy?
Thanks for having me here today. I'm Christy McGowan. I am from Children's Mercy. I am the Senior Nursing Director for Emergency Services. I am a nurse practitioner, have been a nurse also for over 20 years, and we'll just leave it at that. But this is something that's very near and dear to me because I see staff members every day struggling with trying to provide excellent care in an atmosphere that they shouldn't have to work in. And it's not something that we talk about a lot because as healthcare workers, we want to do what's best for our patients, and sometimes we just feel like we just can move through that, and we don't need to make that an everyday occurrence. We need to be able to support our staff and allow them to do their job the way they want to without feeling like they've been attacked.
You, Elijah?
Yeah, good afternoon. My name is Elijah Thompson. I'm the System Director of Security for St. Luke's Health System. I've been there for 90 days. But before that, I was with HCA for 10 years in security and emergency management leadership. And before that, I was in the fire service, actually most of it right here in Overland Park. So I'm kind of familiar with this area anyways. But yeah, definitely, I've seen firsthand the evolution of this problem and our attempts to support staff however we can. So appreciate this meeting as we hope to kind of push some of these initiatives forward and build a safe workplace for everybody.
Okay, thank you. That's a pretty quick run through for a lot of great experience and expertise. So I think we'll have a great discussion today. We'll start with the first question, and the question is, how broad is this problem of violence against our state's healthcare workers, and how long has it been going on? Is it just through COVID? And Alan, would you like to start us off with that?
Yeah, as I mentioned in my introduction, I've been doing this for quite some time now, more than 30 years. And I'll say decidedly this is not a new problem. There's been violence in healthcare like a lot of professions for a long period of time. I think the real question is, to your point, that we've seen a significant acceleration both in the amount of violence, how often we see these issues, and then the degree of violence, I would suggest. It's become a much more risky place to be. But it did start before COVID and is progressed over the last several years. We are not certainly the first state to address these issues. More than 40 states have looked at this. In the profession, at the medical meetings where I go to now, on every agenda at a major medical CME meeting, there is also workplace violence type issues that are being discussed. We know that we have had colleagues that have had violence all the way to shootings within our hospitals that you can read about in the headlines with an all too common frequency recently. And I think what I want to say also is what we're not talking about when we talk about this problem is something that we've dealt with through my whole career, and that is the mental health issues and especially dementia issues that we see in patients, which has been a known part of. I can think of the first time that I had been struck by a patient. It was in my residency, and it was a demented patient, an older man, pretty strong still. And I was examining his heart with my stethoscope, and I reached across him and leaned down. He struck me pretty hard. And what that was a learning experience to me on how to examine one of these patients. It was not an assault from him. He did not know what he was doing at the time, and I now know how to protect myself from it. This is a different degree of violence that we're seeing. This is where it's much more purposeful, and it's much more directed in a way that it isn't one that we're trained as healthcare workers to protect ourselves from, and needing a higher degree of attention to this problem today.
Thank you. Ed, how about a law enforcement perspective?
Well, as I mentioned, I spent a lot of time in emergency rooms as a patrol officer and as a sergeant, and that was more years ago than I'm going to admit on tape. So, but this was going on back then, just not to the degree that it developed into. I did a quick check. We had a bill in 2015 to try to get this legislation passed. I'm not sure that was the first year, but I know we had one in 2015. Our association's gotten involved in it because of the magnitude of the problem that we knew was occurring in our experiences, especially with the emergency room and oftentimes getting calls to the other sections of the hospital when these things would occur. And so this is pre-COVID for sure. And that's one of the things I think we've had to counter this last couple of years. Everybody thinks that a lot of our problems are COVID related, and they really were happening way before that. In addition to that, prior to COVID even happening, when people were having real meetings in person and conferences, I attended by invitation at least 2, I think 3 state conferences with healthcare workers to talk about this very issue and to give them some insight on some things they could do, even absent the change in the law. And so this has been going around for quite some time, quite well into the previous era of COVID. And it's time something happened on it, and we're glad it's progressing the way it is.
Okay, thank you. So I suspect that we've seen instances and examples of this type of workplace violence right here in our community. Elijah, have you got, I imagine there's some stories. Elijah, anything from St. Luke's perspective?
Yeah, to kind of start broadly, I just echo the fact that in 2013, we are easily going to outpace 2022, 2021, and 2020. So again, it's definitely not just a COVID issue. It's continuing to grow. And I think hospitals are a complicated environment. They're already filled with a lot of emotions. We always say some of the best parts of life and some of the worst parts of life all happen under our roof, and we're looking at the best way to manage all of that. I think also I want to note that, hospitals are investing a lot of capital into the safety of their staff through training programs and panic buttons and lockdown doors and additional security staffing. So we are doing our best to try to get our arms around this and provide for a safe environment. And still, the frustrating part is still at times we're falling short. So we're trying to figure out how to make that last step to truly make an impact. Just for awareness too, I think most people may not realize that most hospitals have a workplace violence committee. So we are getting better data, and it's helping to build more strategic plans to address the violence that we're seeing. There's a lot of awareness on a monthly or quarterly basis, depending on the hospitals. We're exactly tracking the number of issues and how we're responding to it. I think hospitals are looking to the best practice across the nation. Violence in healthcare is not a Kansas City issue. It's a nationwide issue. It's an over 5,000 hospital issue that everybody's trying to combat. It's tough. Trying to look at all the many stories that we've seen. I think one of the best ones I could think of that kind of illustrates the issue is a brand new nurse that is so dedicated to her patient. And a patient who was not cognitively impaired got angry, walked up and punched her square in the mouth. This is a 21-year-old girl, fresh out of nursing school, ready to conquer the world, and a patient just punched her in the mouth. And you're blown away. You're like, what level of anger is involved in that, things like that. But she is so dedicated to her patient that she wanted to continue to provide care for him. And throughout the entire experience, even though her lip was bleeding, she was still worried about her patient and ensuring that she was getting the appropriate care. So I think that was one of my favorite stories that kind of just showed the level of integrity and empathy that our staff have, and that we're very sensitive to the fact that we want to be able to provide for these patients in a safe environment. But at the same time, we need some level of protection for our staff as well. Probably like many of the facilities, we look at just recent incidents, many staff concussions, punches to the face, people that have been, bleeding, joint dislocations, people that have been bit. So the list kind of goes on, and these have a ripple effect throughout healthcare as everybody's kind of aware of those, and we're trying to desperately respond to that. A couple things, along with this statute, I think there's some concern that it wouldn't be used responsibly, and I can help ensure that it would be. That we are very, very aware that we have a dedication to patients, whether they're cognitively impaired or not. So with this statute, we are truly looking at a group of individuals that is cognitively aware of their actions, but still chooses violence. Up to including, I've used this example before, an individual who drinks too much, gets in his car and crashes his car, that he is still fully accountable for his actions after he crashes that car. But for some reason in a healthcare setting, there's kind of an umbrella that because he sought care, that becomes, an allowable behavior. And we want to send the message that is absolutely not, because you made choices that resulted in that. I think the big thing about this statute is truly accountability, and that we're asking for some of the same protections that are already allotted to law enforcement officers and school teachers. And the problem is, the stats are there. Healthcare workers are 4 times more likely to be assaulted than any other profession, including law enforcement. And we're seeing our most skilled, most experienced healthcare workers that are leaving frontline care because of the level of violence, and they're going to areas where they have less exposure to that. So now you're backfilling with brand new, less experienced nursing staff, so the cycle kind of continues with that. So I want to throw out one more thing, and the number's probably old, but just kind of obviously we are in a huge staffing crisis, so this is one big piece of this. I know I'd always read that at any one time in Kansas City there's 1,400 open nursing positions. So workplace violence is just kind of compounding some of our already workforce issues that we have. So kind of remain dedicated to providing that safe work environment for these individuals.
Hey, Christy, what have you seen at Children's Mercy?
Yeah, thank you. To kind of speak to his points earlier, most people don't wake up in the morning expecting to show up in the emergency department. So there was a lot of emotion immediately because you're hurt or someone you love is hurt. And when we're talking about Children's Mercy, we're talking about our children, and that's even a different level of fear and frustration when they're not feeling well. And when nurses at Children's Mercy are trying to provide this care, oftentimes there are patients who are creating some of this violence towards them. And a lot of times it's the parents. And again, they are very aware of what's going on. It is a high emotional time, but they're doing things to our nurses that creates that fear of coming back to work, of are there other things that I can do? We've had nurses punched in the face, threatened to follow them home. Lots of discussions around violence, when they see them out in the parking lot or if they ever see them outside of the hospital. They also do things in the hospital where we do have to engage with security. And again, to your point, they still are really worried about their patient and want to make sure that they're getting the quality care that they came to get and that they deserve to get. At the same time, our staff deserve to provide that care in a safe atmosphere, and to be able to be excited and not afraid to walk through the doors the next day. And it's been very busy. We have had higher acuity, higher census, lower nursing numbers, and lower provider numbers as well, as we're really trying to care for these kids. And when our nurses are afraid to come to work, they find other places to go. And that is scary in itself, because when we do arrive at that emergency department, we want those skills to be taking care of our family and our kids. And we need to be able to protect them so that they can do what they went to school to do. Nurses are typically in there not for the money, I can tell you that. It's really because we really care about our patients and we want to do what's right, and we want to make sure they're getting good quality care. And when we're afraid to walk in the door, that hampers that, and it creates the desire to go elsewhere.
Okay, thank you. Alan, you've been at this for a long time and now with a new hospital. What can you share with us?
Yes, I hear the stories from Elijah and Christy. All I can say is they sound very familiar. We had the opportunity to design a new hospital with state-of-the-art security facility features that you can put into a new hospital, and we did. And we did it as we were thinking through, I was thinking through some of the most dramatic issues that I have seen in my career. And one was a nurse that was punched and hit so hard it knocked her out, and she landed, hit the floor, hit her head, had a closed head injury with a fractured skull, and she went from that patient's room to our ICU. And she spent over a week in our ICU, over 6 months trying to get back rehabilitated after a closed head injury, and then never went back to bedside nursing based on that trauma. And she did go back to work, but in a different arena of nursing, but not at bedside nursing, due to that one moment in time. And then the second was at the last hospital I was at in Colorado, we had a weapon fired in our emergency department during the time. Fortunately, nobody was injured. Somebody hit the arm, and the gunshot went through the ceiling. And that was before COVID. That was in 2017 when that occurred. So when we designed we put a lot of capital expense into designing with bulletproof and shatterproof glass, a lot of secured areas where you have to card access in, and yet you're always left with a case where a clinician needs to go see a patient physically in the room. And you can't mitigate that risk other than trying to do the best you can for the provider in that moment in time. And it's a real issue. We are obligated to, based on laws, EMTALA laws are called, to evaluate every patient that comes into an emergency department. We have to do a screening evaluation for medical stability. And it's an area of grayness for law enforcement where we have people who are either maybe substance abuse or having some type of mental health crisis that may have a underlying medical cause, and they come into the emergency department, and we have to provide a medical service evaluation, and we want to do that. But it's a gray area that a lot of times these truly aren't medical problems that we're seeing in the emergency department. And sometimes we're left taking care of that and at a higher risk environment than we would be in other places. We would never leave that patient alone without a law enforcement or other types of security. And yet at times they're dropped off in our emergency department and they spend hours there in a very high risk situation. And most recently, here locally, we had an emergency department provider at Advent Health who was attacked by a patient and a visitor with that patient at the time and left with a concussive illness and left his shift that night because of a concussion. And it was in one of those environments, he was in the middle of an evaluation exam during that time frame. So yes, we're having that happen here, and even with the most state-of-the-art security that you can put into the building, it doesn't mitigate. We do believe that some of this legislation sends a strong signal that we take this seriously, and it actually places attention that we need to approach these both as a patient, but also as possible someone who can commit violence, and not ignore both of those when we're in the unknown situation of the evaluation that we provide, especially in our emergency departments.
Okay, so we've got a widespread, serious problem with a lot of negative ramifications. What are the hospitals doing about it today? Christy?
So I think we're doing a lot of data analysis to see how we can impact it in the best way. We have increased security. We have metal detectors that families have to go through before they can enter the hospital. We do have processes in place where we call it a code strong in our area, where we get a group of people to help with the patient or with the family to de-escalate that. We have staff training that's required for them to learn how to respond in these situations, whether that's to try to help de-escalate the individual or to just get out of the room and take care of themselves. We have also invested a lot in our well-being center at Children's Mercy, so that staff have somewhere to go and have someone to reach out to talk to. Again, because this is their profession. This is what they're wanting to do to help. And then when they end up in that situation, they need to be able to talk through that and process that themselves and make decisions for them. So we have daily work going on to try to improve this process and to improve the safety. And I think this would really help us be able to do what's right for our staff.
Heidi, what about KU?
Sure. So we have a workplace violence prevention committee that has put forth several initiatives to help keep our staff safe. We have similar things, the metal detectors, panic alarms. We are very fortunate to have a police department on site. I think that has been very helpful and very supportive of our staff. We did a campaign a few years ago called A Safe Place for Healing, and it provides very clear guidance that we have zero tolerance for disruptive behavior from anyone who is within our walls. And we list out specifically what we consider disruptive behavior. We even indicate that we will file a report if we need to based on those behaviors. We have some programs in place for patient care. We have a complex behavioral health patient program that has been really helpful in getting an interdisciplinary team around the table to develop interventions to ideally prevent the escalation from happening and to ideally keep our staff safe. That program has been very beneficial. We also have a behavior response team that provides resources to escalating situations to help provide support and de-escalate. Talked about the importance of supporting our staff. I do agree that this legislation would send a message to our staff that they're cared about, that they matter, they're seen, and that, we as a state want to keep them safe. We also have wellness programs in place for our staff. We have conveyed to them the importance of reporting, and we had a campaign called You Report, We Support. And, the support we can offer is a second victim peer support program. We also have an employee assistance program and other wellness initiatives to provide resources for our staff.
Okay, so I expect these are steps that are pretty typically taken by hospitals across the board. But are the crimes being underreported? Well, why can't the hospitals just go after the people that are the perpetrators, the people that are causing the problems? Heidi, you want to pick up on that?
Absolutely. So we have pretty good reporting at our health system. I think just letting staff know that we're going to report them or we're going to support them if they report. We really encourage that reporting process. But there are times that nurses and healthcare workers choose not to file those reports. Some feel that, well, there wasn't an injury, it's not that big of a deal, or, there are still people that feel that violence is part of the job, and we're really trying to shift the culture away from that. In order to file charges, though, you have to be the victim. So the hospital, with the laws as they're written right now, they are not the victim, they're a third party in that case. And so, this legislation would help that. And I think that would help the organizations be able to better support their staff in these situations.
Okay, and Ed, how does law enforcement fit in?
Well, law enforcement fits in because the first step in the process of prosecuting a person for violating any crime is reporting it to the police so it can be recorded and investigated. And so that absolutely has to occur. I think it's important to realize every crime is underreported. There is no crime that's not underreported. The more violent the crime, the higher the percentage of those that are reported. You get down into property crimes, and there's a lot of them. How many of you have had something stolen off your front porch and never called the police about it? And there's a lot of reason for that. The one thing that always disturbs us, it disturbed me as a chief, it disturbed me as a patrol officer, is when people feel like they don't want to report because I don't want to bother the police, or they can't do anything about it anyway, or somebody else talks them out of reporting it. Those are the things that always kind of bothered us. And so one of the aspects of underreporting is figuring out how much is it really underreported. And one of the side benefits of passing this bill is going to be that we're going to be able to see in our data, in the statewide crime data, we'll be able to see how many of these battery cases, how many of these interference cases, if we get that law passed, actually are occurring to healthcare workers, because it'll be a separate subsection in the statute, which means when we charge it, that's where it's going to be charged, and we'll be able to see that data. Today, battery cases of a healthcare worker are cataloged in our record systems the same way as a battery to anybody else. And so we can't go into the data and separate out how many of our battery cases are healthcare workers versus how many are non-healthcare workers. So it's going to be one of the benefits that wasn't the main purpose of the bill, but it'll be one of the benefits that we'll be able to see of it. So that's important. And the process that's followed once we get the case kind of differs depending on whether you're going to file these charges in a city court or a district court. So most of our hospitals are in cities. Most of them in cities large enough they have police departments. And so most of these are being charged through municipal courts if they have those statutes. If they don't have battery statutes, which some cities don't, they just send everything to the district court of that nature. Then it's a different process. But once the police get done with their report, there's a couple of things that happen. If it's in the city court, we can actually issue a citation to that person that actually starts that prosecution process. If it's not charged in the city court, it's charged in district court, then we send our reports in, and it's actually a prosecutor decides whether they're even going to file the charge at all. And that's out of our hands. That's in the prosecutor's hands. So one of the things that I talked a lot about when I did the conferences several years back was encouraging the hospitals to reach out, and not just the nursing staff in the emergency rooms, but the actual leadership of the hospitals to reach out and request meetings with your prosecutors and with your law enforcement chiefs of police and your sheriffs, and express to them how serious this problem is and why we need good follow-up on these cases, so they really understand this is important to spend your resources on. We all have resource problems, right? Police have to pick and choose sometimes what calls we're going to respond to. Prosecutors have to pick and choose what crimes they're going to prosecute. Healthcare workers have to pick and choose sometimes the things we do, especially in the preventative area, depending on what our resources are. And so all that plays into this. But above all, they need to be reported, and we encourage that. And that is the first step in the process. If you don't report to the police, they ain't going anywhere. And so the support that was talked about that's given to the employees, very important. Some of them are reluctant to do that. That's something we heard early on when we got into this back in 2015, 2013, and that was very quickly remedied, I think, by the hospital administration reinforcing to employees that, hey, we do have your back on this and we will support you through this process. So all that's very important.
Elijah, what are you seeing?
Yeah, very similar experiences to everything that you guys have stated. You know, Missouri has a very similar statute that also covers interference with healthcare, and then also covers an increased penalty for assaulting healthcare workers. One of the experiences I was going to bring up is from Florida, where before I came to St. Luke's, I spent a year in Florida. They also have a statute in place, and I think it's mainly the county, but the DA's office was very, very educated on that statute. Local law enforcement, very well educated, very well trained on that statute, and hospitals were as well. So when something occurred, there was usually a meeting at the hospital that involved a physician, a nursing leader, security, local law enforcement, and they all kind of gathered up and he said, you know what, does this apply? And from that, the law enforcement would, determine whether or not charges were appropriate. The person was cognitively aware of their actions and still acted out in violence and aggression. And that was probably the smoothest area where I've actually seen that apply, when everybody was educated, everybody knew exactly what was in the statute, and people were held accountable. And I think there's a prevention that's kind of gets built into that as well. You know, we talk about proactive things we do to keep staff safe. We talk about reactive things, reactive things like panic buttons and increased security. Proactive things is a lot of times having conversations with these patients whose level of aggression is going up, and we're telling them, hey, we have a zero tolerance for violence and aggression against our staff. Here's the statute. I think most people are aware that if you assaulted a police officer, there's an increased penalty for that. And this is us explaining to these individuals, again, hopefully drawing the line in the sand early on in their behavior cycle that, hey, this behavior is unacceptable and this is the statute that you could actually fall into. In fact, we're seeing a lot of hospitals, and probably some of your hospitals as well, that are putting signage up at their entrances that basically state emphatically, we will not tolerate violence and aggression. And at the bottom of a lot of those signs, they a lot of times will list out the statutes. So we don't have that for Kansas, but we have something already in place for Missouri. And these are also signs that we're putting up at all of our nursing stations as well, making them aware like, hey, we are going to protect you. There is a lot of reservation in reporting, and I think security, I'll speak for security, I think we want to support staff as much as possible. I can tell you that we will personally call law enforcement. We will personally make the connection between the employee and law enforcement. We will support them. We've escorted staff to and from court to make them feel more comfortable. The difficult part is the staff member knows at some point they may have to sit across from a courtroom from the person that punched them in the face. So it is a very difficult process. So even beyond our level of support, there is still some hesitation in place. But with the statutes, there's ways that the hospital, as you guys have already mentioned, that we can kind of take action on behalf of the staff, where before we were pretty well restricted to trespass and property damage. But since this is a crime against a specific victim, we needed that person to move the process forward. I think there's also a little bit of concern, and I think this is where it kind of falls off, not picking on any individual DAs. I just think there's, probably a lack of understanding of, what this looks like within healthcare. And a lot of times these charges get dropped because they're not as familiar as they gathering the details, looking at how to actually proceed forward with a hearing on this case, that there's kind of this umbrella of protection that happens in healthcare, which is what we're trying to break down a little bit right now.
Okay, it sounds like the instances of aggression and violence are increasing quite a bit, and why has this become such a problem now? Are we just more aware of it? What, Alan, from your experience?
As we've already mentioned, the panel's already mentioned, this isn't a new problem, but it definitely is getting a heightened awareness to it. And I think there are multiple factors that go into it. And again, I think some of it is because the frequency is increasing and the level of violence is increasing. So I think that in itself draws more attention. But the other factor that I think bears notice is that the workforce in healthcare right now is one that has gone through a lot of turmoil through the pandemic. It is a challenged workforce. It is a tired workforce. The term that we've been using, and you've probably seen in your industries as well, is burnout. And it is high. And it is driving key members of our workforce out of the workforce. And violent episodes drives them out more quickly. I mentioned one where a nurse was not able to return to the bedside. I bet all of us have episodes where we know someone who has experienced violence and it was the last straw, and then they walk away. Right now, we can't replace them as easily as we were before in the pipeline for that. And overall, I think for the profession, which is a caring profession of really highly trained, compassionate people coming in, we're having a harder and harder time drawing people unless we address issues like this. We need more to fill these roles. And I think for Kansas in particular, there have been more than 40 states that are addressing these with legislation. And I think we have to be aware, if we choose not to, what signals does that send? Missouri, you mentioned, has laws in place. And what we're looking for is the same type of interference laws that EMS and some of law enforcement and first responders have. And if you choose not to act while those around you are acting, I think that in itself sends a message. So I think all of those factors are bringing us this issue to attention, and it's why we're here today to advocate for this for our people and for our future to be able to provide care to our communities.
Okay, back to you, Elijah.
I think of this, and, in a lot of industries, if they were to identify a risk that was causing harm to their people, they would just kind of eliminate that risk. And we don't really have that luxury in healthcare because we are truly in the people business. So we are looking to mitigate the risk, do everything possible to keep our staff safe while being opening and caring and continue to be dedicated to our patients. So with the people business, I also think about if you were to go into a coffee shop and you yelled and screamed at the people that were working in there, they would probably trespass you and remove you. And it's also really complicated within healthcare. We have patients that are angry, but we are still dedicated to providing them with care. I always jokingly tell my security officers that we allow people to be angry. We don't allow people to make threats and act out violently and aggressively. And actually the same thing holds true with a visitor. Like, the solution is to just remove everybody. But it's definitely not that simple in healthcare because many of these visitors are needed to help provide appropriate care to their loved one. So it's this constant, kind of back and forth, ensuring that we have a safe environment for the patient, but also for our staff. So I think the balance is unique. That's not seen in a lot of other industries. And like I said, there's a lot of clarity, I think, that comes with this statute. As you guys have already mentioned, I think it definitely sends a message to all Kansas healthcare workers that we are dedicated to protecting our staff. But in turn, I think that equates to a stronger healthcare system. You take your loved one to the hospital, you're going to have the best, most experienced, confident nurse there to take care of you. And I think good, solid health care can only happen in an environment like this where nursing staff aren't afraid of being hit, kicked, punched, things like that. So on one side, I can say this is absolutely the right thing to do for our staff, for the healthcare industry. I can also make a very strong argument this is the best thing to do for patient care and for your loved ones, that true healthcare only happens in that safe environment.
Christy, your thoughts?
Yeah, I think the biggest thing that concerns me is keeping those experienced nurses at the bedside to be able to provide that care. At Children's Mercy, again, we're dealing with people's kids, and sometimes it's really hard to keep staff engaged in the fact that they're oftentimes helping families watch the death of their child. And there's a lot of things that go into working as a nurse in a pediatric hospital that is hard. And to add to that they have to then fear for their safety when they come in, a lot of people just can't do that. They won't do that. There are other opportunities. We've actually lost more nurses out of the emergency department to non-clinical areas than we lost to travel or any other types of things like that in the past several years. And it's not just about the pandemic. It really is just about people are tired and they're afraid and they have other options now. And that scares me as a mother. I want the best to be able to take care of my kid when he's in the hospital, and I know you guys want that too. And that's what we've got to be able to show these nurses and physicians, that we care about their safety and we care about what they bring to our community. And being able to be safe at work is something we should all be able to do.
Okay, so we know we've got a serious problem in our community, and it's common throughout Kansas and other states. So what are these other states doing about the problem? Alan, you want to kick us off on
Yeah,
that?
much of the legislation is to increase the attached penalty to assault on a healthcare worker. And we've already mentioned these laws are very similar to those that you see with first responders, EMS, firefighters, law enforcement. And it's to bring that heightened sense of awareness that we have community members that are here to serve who shouldn't be subject to assault while they're doing that. Nebraska and Colorado have enhanced their penalties already against health when there's assault against healthcare workers, and they turn, as we have here, interference laws against the activity that that provider is trying to provide in the time, interfering with that essential activity. And EMS, as we say, already have that here in Kansas. This law has already been enacted with our EMS workers, and we would like to see that designed similarly for our healthcare providers in our ED and in the hospital and other healthcare settings.
Okay, thank you. Heidi?
I concur with everything that you said. I mean, we just want these additional protections. We've been asking for them for years now. This is taking a tremendous toll on our healthcare workers in many ways. I mean, they're leaving the profession. That's not good for any of us, and it's affecting them emotionally. So we really want these two things. We want those increased penalties for assault and battery of our state's healthcare workers to be on par with other states, first responders. I mean, we should be the same. And we want to have that added crime of interference with healthcare services modeled off of the interference statutes currently in place for EMS. So it's really important that we move forward with these. It's time.
Okay, thanks. Ed?
Well, several comments already about what other states are doing, and that's one of the things our associations always look at when we get involved in legislation, is to see if there's similar legislation so we can kind of see, what's working in other states and make sure we craft the legislation appropriately. One of the first questions we seem to always get is why should there be a carve out specifically for healthcare workers? And to me, that's a pretty simple answer, but it apparently isn't that simple. The first thing is that when you look at the carve-outs for like law enforcement and firefighters, when you have people who are providing a service that offers protection to other people's safety, and somebody batters somebody trying to do that performance, then they're keeping those services away from the other parties that the firefighters, police officers, healthcare workers are trying to assist. And that in itself raises the level of the damage that's incurred by this act. It raises it above a battery to anybody else that may be walking down the street, because that battery doesn't interfere with some third party getting life-saving services from police, fire, healthcare workers, and others. And so that's why it's important to have this carve out. In our bill, it was mentioned the other states do interference and battery enhancements. In our bill, as it was introduced, we did both. The interference law was actually crafted after the exact same concept and provisions that is offered to the interference with the state legislature, district or county boards, the Board of County Commissioners, city council meetings and things like that. You interfere with those, there is a specific crime for that. And the penalties that we sought in that provision in this bill were identical to that. And I think it's hard to argue that interfering with a healthcare worker to the point that they can't provide that care to a third party that's not involved in the incident is certainly as serious as it is as disrupting a public meeting. And maybe more so, I would argue. And so for that reason, we thought the interference was well-founded and at the right level. On the battery, one of the things we often hear is, yeah, but what about these people that go in and they have dementia, or they have a head injury and they don't really know what they're doing, and well, that's not a crime, because to have a crime of battery, you have to knowingly strike this other person. And a person in those conditions isn't doing it intentionally and knowingly. They're responding to their medical condition. And I think that was addressed earlier in some of the comments. And so when you look at the case of the battery and the enhanced penalty in that, we're talking about people, as one of the others mentioned, you can't walk away. You can't deny health care services to a person because you just got battered by that person or by that person's family member or even some third party. And just like police and fire, you can't say, well, I got battered, so I'm not going to put that fire out, or I got battered, so I'm not going to investigate this crime. And then secondly, you have to look at the severity that crime, the commission of that crime, has committed. The severity level of crime is supposed to be based on the impact that crime has. And the impact on a healthcare worker or a police officer or a firefighter getting battered is much higher than it is for a simple battery on a person not providing emergency services. And so those are the reasons that we chose to get involved in this. We think it's a very important cause, and that's why we chose to get involved. So those are the things that I think are being done. They've been shown to be at least beneficial. Nothing you're going to do is ever going to stop a crime. I don't know if we got any laws on the book. Let's just take battery, for example. Battery law has been on the books since forever. And we still have battery cases. People still punch each other. And so you're never going to completely eliminate the crime, but they do reduce it. And to reduce it, you have to have, one, a law in effect. Two, you have to have enforcement of that law. Three, you have to have prosecution of that law. And four, you have to have a penalty that goes along with that violation when it's proven you did it. And this is just, getting the law passed is just one. But all of those things work together to reduce crime, no matter what that crime is. And we fully expect that's what we're going to see in Kansas when we get this law passed.
Thank you. I'm afraid I'm going to get accused of being master of the obvious with this next question, but is there any chance that this legislation won't solve the issue? Christy, how about some strengths and weaknesses, I hope?
Yeah, it's not going to, one law is not going to solve the problem, but it's a step in the right direction. It's, again, showing staff that we are going to support them. It's giving us the opportunity to have something happen to the people who are creating these issues for our staff. It's also hopefully going to show our providers and our nurses that it's worth staying where they are and not walking away from the bedside, because we are trying to work with them to fix this problem, even if it doesn't completely solve it as soon from the beginning.
Heidi?
So in 2021, we surveyed our staff about their perceptions about workplace safety. And we asked some questions, particularly around workplace violence. And one thing that came out very clear from that survey is that our staff want to see consequences for the perpetrators of violence. So this legislation would help tremendously with that. I mentioned earlier, I think this would go a long way in helping healthcare workers feel supported and valued. And I think that's really important. I mean, they've been through a lot during the COVID pandemic. And so I think this would help them in helping reduce, stress and burnout. I think this legislation would also give tools to both the prosecutors as well as hospitals to be able to do something when they can.
Thank you. Ed, anything to add?
I think I kind of jumped ahead and answered that one already. Just let it go at that.
All right, then I'll just throw it open to the entire panel. Is there anything that's occurred to you during the discussion that you'd like to mention or have a follow-up on anything? Now's your chance.
I think I would just end by saying I think everybody up here is obviously very, very passionate about this subject, and it's because we've all watched it grow and grow over the last 10 years. We've cleaned up the pieces repeatedly. We've sat with staff that are crying. They can't understand how, when they're trying to help somebody, that somebody reacts with violence. So, I think as the director of security, there are numbers and charts, workplace injuries and things like that. I think for me, every single one is painful because I feel like there's a lot of responsibility in my role to make sure these people come to work and they leave without being injured in the environment they're working on. So I think this is kind of us trying to gain everyone's attention, the call to action, we're watching this get worse and worse. It's not going away like many might have thought it would. And, I think personally, not only do I want a safe environment for my staff that I have right now, but I also think, I have 2 young daughters whose mom was a nurse, and both of them have said, Dad, I definitely want to be a nurse. So it's like, how can I, tell them like, yep, that's a great career without doing everything I can to make sure they're stepping into a safe environment to, to take care of people, to fulfill that passion of theirs that they've had at 15 and 12, which I think is admirable. So.
Anyone else?
I'll just throw in one other observation I've had over my years of listening to testimony on this, and it really hasn't been talked about here, but the impact of these crimes is much different in rural areas than it is in urban areas. One of the questions that I kind of stunned me from in one of our committee meetings was, well, why don't the hospitals just hire security staff to be present at all the times? That's like, well, why don't you hire a police officer so they're always present when the liquor store gets robbed? Where you can't have them everywhere, and security is expensive. And the most expensive part of security is personnel, like it is with anything else.
That's because we're worth it. Sorry.
I don't dispute that.
Yeah.
But small hospitals, we all know, are financially stressed, and some of them are on the verge of collapsing because of that. And to add the expense of security personnel to be 24/7 in a facility is just not even doable in those rural areas. And the other thing that I've heard that impacts the rural areas, and it makes absolute sense, is if you go into the emergency room at KU Med Center and you batter one person, you're not going to shut down the entire emergency department. You go into an emergency room in Colby, Kansas, and you batter one healthcare worker, you're probably going to either shut down or seriously inhibit the progress of in that emergency room. And so we don't talk about that often about the rural areas, but to me, the impact there is even worse, just because of those sheer numbers and the cost factor, and those hospitals are hanging by a thread now, and we certainly don't want this to be the thing that breaks that thread. So I just throw that thought.
Sounds good. Well, we've got some extra time. I guess I'm going to take a chance and recognize that there are a number of legislators that have been able to make it here and attend. We really appreciate that. Any comments from you all? Yeah.
Representative Stephanie Clayton, I represent for the Leewood for Village of Overland Park. So my question is this: I've heard some of my colleagues have questioned some of this legislation, specifically by saying, well, but what if a nurse is, inappropriately touching or undressing one of my children, that sort of thing. I'd be curious to know how, especially from Children's Mercy, how common that type of thing is, both in regards to the concerns that this hypothetical parent that may or may not exist, would have, and then how often there are assaults on healthcare workers from parents who might disagree with what they're doing with their children. So that's the main concern I've heard about this legislation, is a parent-child, protecting their kid kind of thing.
Yeah, I think during the investigation that would be looked into. They would there's always investigation of having conversations with the staff who are involved with that, anyone who is taking care of that patient. There's also guidelines around who's in the room when people are being undressed and when exams are taking place. So it wouldn't just be the nurse said this happened, and so we're going to file charges. There would definitely be an investigation around that. I mean, I don't think it happens frequently, but anytime there's a parent concern or complaint that's brought up, they are investigated, whether that's from, I felt like they weren't doing the appropriate care to, I didn't like how someone talked to me. It's always addressed in a manner that they find out what really happened.
And I don't know if I can add on real quick too. I mean, hospitals employ patient advocates that do nothing but involve themselves in those situations, and their job is to evaluate both sides of that conversation. And I think it's important to note too that, situations where parents are angry, questioning care, things like that, I don't think we see that as a situation where this statute would apply. We would say as a parent, yeah, you definitely have the right to be angry and to question care and to be a participant in that. I think we're talking about once this crosses the line to where, there's physical contact, shoving, kicking, punching, threatening, things like that is where we see this statute kind of coming into play. Not for situations like that, which is very, very common in any healthcare setting. So,
Yeah, and a parent can question care without assaulting someone.
absolutely.
Anything else?
Let me just add one thing to that answer there. When we get involved and we investigate and record the incident, we're looking at who, what, where, when, how, why. And the why is a very important part of that. And that gets into the circumstances around that battery or assault. And that would be documented. If that even progressed then to a prosecutor, the prosecutor is going to look at that. And they have a lot of discretion at that point to look at those cause factors and what was going on around the total circumstances. And they may then make that decision not to prosecute. There's other alternatives they can seek to prosecution. And they can look also at that person's history and things like that and make a valid decision whether that fits the criteria, what was intended with this law or not.
Senator Petty, I have a couple of questions. The issue about the things that you're already doing, and I heard no mention of cost about those things that are already occurring, like whether it's staff, safety committees, or whether it's signage or safety doors. And so I know that's so talking about whether it's the comment about as you said, someone saying in committee, why don't they just hire more staff? That's just really that's a personnel issue. That's just really one more factor. But right now, and I'm making a big assumption here from what I'm hearing, they're already spending a lot of money to provide safety. So has that been, and since I haven't sat on the committees that approved this legislation, has that been shared in those committee hearings about what's probably, because personnel is a big thing, the safety is the issue, but the question might be, well, what are you doing to help with that safety already? What financial, I'm asking what financial toll that's taking on, because that's costing me as a consumer already by going to whatever hospital.
I think the healthcare representatives in the committee rooms have done a very good job of responding to those questions and covering the cost factors and the other things that they've been doing to try to alleviate this problem and the support they give to their employees and all those things. So, they do get answered in those committee rooms. The problem is, as you know, answers in committee rooms and testimony in committee rooms are heard by somewhere between maybe 8 and 20 people. And when it gets to a vote on the floor and comments are being made on the floor about a bill, that's a very small percent of the people in that room that are actively participating in the process have heard that firsthand. And there's just no way with the number of bills that go through there that you're going to know every testimony that was given and everything that was said, every question that was asked and every answer that was given in those committee hearings. And sometimes I think that gets lost in the process up there. And there's been very good answers to those in the committee room, but they don't get very good answers in the floor debate.
I'd also say that I think I think if somebody came up with like, you know what, here's the solution to workplace violence, it's really expensive, I think hospitals wouldn't flinch. They would immediately go after this. This is effective. This is going to work. Yep, it's really great. Let's go exactly after that. So I think the challenge is looking at effective strategies. What is actually going to work? And I could say for St. Luke's, it's 7-figure investment across our system in safety features. And you already alluded to some, like some of the badging access, the panic buttons, the lockdown features that provide safe locations for staff to kind of protect themselves. And I think also it kind of goes back to the point I was making too, that like additional security officers, depending on how they're used, they need to be used effectively. Otherwise they become a reactionary force. Something happens, the assault has already occurred, and then they're supplementing to continue for the safety. So how do we best use those and some of our technology and our strategies and the prevention side of things, the proactive side of things to prevent the event from even occurring? And that's why I said, you know, it was effective in Florida, where we would approach somebody and say, hey, this is exactly what the state statute says. And some of these are individuals that I dare say every single time they came into our hospital and they were cognitively unimpaired, they would assault a staff member. Almost every single time they were there, they would cause some kind of an issue. So it was an opportunity for us to explain the statute, that there's an increased penalty, and some of their other actions could actually fall into this interference clause. And then when it's documented, everyone's educated on it, law enforcement would show up and they would hold them accountable because it was crystal clear where that fit into everything. But yeah, I mean, I don't mean to speak on behalf of everybody, but I think there's a significant investment, and all of us are kind of scrambling, you know, like what is that best thing that's going to get to the bedside, get to that individual nurse and make them feel safe and protect them from being injured.
Along the lines of the underreporting, but yet you mentioned posting for both the patient and for the workers about that, you know, this is a safe environment. There's, you know, this is what will happen if you violate that space. And I just wondered if you have, because from an employee perspective, that's that actually I would think would show, hey, there's a reaction. My employer is taking a real action here and listening to me, even though it may not totally change everything. So have you, in those situations, in the hospitals that you're doing that, do you feel like, from a staff perspective, that they feel that they're more valued when they see that kind of posting throughout the working environment?
Yeah, I think that absolutely helps staff feel supported, and they see the clear message and what the expectations are. It also gives them something to, you know, speak back to patients when needed, and to remind them that, you know, we are a safe place for healing, and these are the expectations we have and what we will not tolerate.
We aggressively review every act of violence within, towards our healthcare workers. So it gets an in-depth review. And I do believe those words matter, but our workers are also looking at what their communities are doing. So they're very well aware of these discussions and what our state is doing and what's being done in other states. And they're expecting similar type of response. They are highly aware of that. And we do invest a lot with de-escalation training. We invest a lot with active shooter drills. And we talk more about safety and security than we ever have in my experience. And I do think it matters to our employees. But again, they're watching as we have these type of discussions as well.
Let's do one more quick one, Senator Corson.
Yeah, Ethan Corson, Northeast Johnson County. It just strikes me that I will just say to add to that, I'm strong with the legislation, because it strikes me that we're at kind of a crisis level, no matter how you measure it, it's staffing. And the fact that Missouri has these protections in place and they're 10 minutes away, and if Kansas doesn't, it feels like that's another way that we're giving Missouri a leg up on Kansas in terms of staffing levels and getting the employees and addressing this from a workforce angle that we need to be doing to get the number of healthcare workers that we need. So that was sort of my takeaway from listening to this. I don't know if you have any comments on that.
Anyone have anything to add to that? I think it's hard to debate.
I agree.
Hard to-
No, I agree.
We agree completely.
Well said.
Yeah, I'll add to that is that being Children's Mercy, we have a campus in Kansas and a campus in Missouri. So we definitely notice that there's a difference, and staff are aware of that.
Okay, well, I think we're just a couple of minutes past our designated time, so I want to thank the panel. Great information, insight. We really appreciate you being here and sharing this with us. I was also negligent at the beginning and should have thanked Tara Mays and the Kansas Hospital Association. She kind of took the bull by the horns and got this thing going and got it organized. So came up and got us done. So thank you very much, and thank you all for being here. We appreciate it.